Jareth and colleagues performed a prospective study of 200 patients undergoing electrodiagnostic testing to evaluate if EMG or nerve conduction studies are more painful from a patient's perspective. This study gave 200 subjects a post-exam questionnaire as to which was more uncomfortable, nerve conduction studies or needle EMG. They examined variables such as age, gender, and number of muscles or nerves sampled. Patients were more likely to experience greater discomfort with the nerve conduction studies if they were older, had higher BMI, had polyneuropathy, or had 11 or more nerves tested. A larger percentage of younger patients who had lower BMI found the EMG portion to be more painful. The more nerve conduction studies performed, the more uncomfortable this test was deemed, but the more muscles sampled by EMG did not increase the perception of discomfort. They noted that certain nerve conduction studies, such as testing for median neuropathy at the wrist, were perceived as more uncomfortable. The medial gastrocnemius and biceps brachii were the two most uncomfortable muscles with EMG. Thus, this study can help to predict what types of tests may be most uncomfortable before starting your examination. You could use this information to educate your patients beforehand. There is debate among electromyographers about what needle electrode type is most uncomfortable for patients. This question was addressed in an older study by Stroman and Dalby. Pain during needle EMG was measured based on needle type and needle movement. This double-blind study evaluated 48 patients with diverse clinical problems but no sensory loss. The results demonstrated that when an examiner used large needle movements within a muscle, monopolar needles were less painful than concentric needle electrodes. However, when using small needle movements of around 1 millimeter, pain associated with concentric needles was not different between needle types. Examiner experience, gender, previous EMG, reported pain tolerance, pain on nerve conduction studies, and other factors did not predict the amount of pain during the needle examination. So, no matter where you stand on this debate, it seems that the needle handling technique, specifically using small needle movements, plays a large role in lessening pain regardless of electrode type. This study evaluated the presence of hematoma within the tibialis anterior muscle after needle EMG insertion in patients taking warfarin or aspirin anti-platelet therapy. Ultrasound evaluation of the tibialis anterior was done 30 minutes after needle insertion in patients taking these medications versus controls. Results showed 1.9% warfarin patients with an INR above 1.5 and 1.8% of the aspirin patients had a subclinical hematoma defined as a small hematoma without clinical symptoms. No control patients had a hematoma. Thus, needle EMG carries low risk for clinical hematoma formations when the tibialis anterior muscle is studied. It is unclear if these results can be generalized to other muscles, but should give practitioners confidence to study patients if they are taking these medications. In a study focusing on hematomas caused by EMG of the paraspinal muscles, Gertkin and colleagues evaluated the incidence of MRI-detectable hematomas following paraspinal EMG. They performed a retrospective review of patients who underwent paraspinal EMG and subsequent concordant level spine MRI. A total of 370 charts, 431 MRIs, met the inclusion criteria, and 161 patients were on some type of anticoagulation. No hematomas were identified on MRI following paraspinal EMG performed within 1 week of the exam. It is suggested that there is a lower risk of developing a hematoma following EMG of paraspinal muscles than previously reported. In a related study, London and colleagues looked at the risk of paraspinal hematoma formation after extensive paraspinal mapping electromyography. A 50 to 75 millimeter monopolar needle was inserted at each of 4 sites at L2, L3, L4, and L5 with 3 different orientations. The needle was inserted at approximately 5 millimeter increments from the most superficial aspects of the muscle to the spinous process of the hub of the needle. No patients were on therapeutic anticoagulation, and MRI was performed to check for hematoma formations in 54 subjects. 2 MRIs demonstrated definite paraspinal hematomas, while 10 were found to have possible hematomas. All hematomas were under 15 millimeters, and none were close to any neural structures. There was no relationship between MRI evidence of hematoma and either the timing of the EMG or the use of aspirin or other non-steroidal anti-inflammatory drugs. The authors conclude that extensive paraspinal mapping can be considered safe in the general population and those taking non-steroidal anti-inflammatory drugs. The safety of electrodiagnostic studies was also reported in an earlier paper. In 10 patients with implanted cardiac demand pacemakers and 5 patients with ICDs, the authors found none of the nerve conduction study electrical impulses generated from the left fibular and median nerve and with left Erb's point stimulation in 9 patients were noted on surface ECG or detected by the atrial or ventricular sensory amplification. There were no untoward effects on pacemaker or ICD function with nerve conduction studies at any site. Nerve conduction studies are still considered contraindicated in situations with breach of the skin intravascular barriers such as temporary transvenous cardiac pacemakers. But this study highlights that you should feel comfortable employing electrodiagnostic studies in your patients that need this workup who have implanted cardiac devices. With needle EMG, some physicians may be concerned that the electrode could damage muscles and cause a spike in creatine-phosphokinase CPK levels. Finsterer examined if muscle enzymes are elevated immediately after or 24 hours following EMG studies with disposable concentric needle electrodes. They controlled for age, sex, muscle, number of investigated sites, and previous CPK elevation. In 53 subjects, muscle enzymes were not different before, immediately after, and 24 hours following the EMG. Muscle enzymes were not different between patients less than or equal to 60 or greater than 60 years of age. Apart from the higher CPK in men than women, muscle enzymes were not different between the genders. Apart from CPK, muscle enzymes were not different between the brachial biceps and anterior tibial muscle. Muscle enzymes were not different if less than or equal to 20 or greater than 20 sites were investigated and were independent on pre-EMG CPK levels. In conclusion, this study shows that muscle enzymes do not increase with disposable concentric needle electrodes, irrespective of age, gender, muscle, number of investigated sites, and pre-EMG CK levels. This concludes part 1. For more tips on how to make EMG testing safer and less uncomfortable for your patients, please watch part 2 of this video.